bring warm greetings in the precious name of my Lord and Savior Jesus Christ. Welcome to our 20th Mnemonic in internal medicine. This time we're breaking down the CHADSVASC scoring system. So, one day, 2 red blood cells were talking to 2 platelets inside one vessel. And one red blood cell said, "I heard you two finally tied the clot." The other one said, "Coagulations." So, we know that the most common arrhythmia that we encounter in clinical practice is none other than our beloved atrial fibrillation. Now, cornerstones in management of AF include maintaining hemodynamic stability of the patient, rate or rhythm control, addressing underlying the cause or precipitants for the AF, and of course, the decision on whether or not to anticoagulate the patient. So essentially, all patients who have some degree of structural heart disease, especially valvular heart disease with AF, have to be anticoagulated with warfarin as a rule because their risk for clot formation and subsequent stroke is very high. However, those with non-structural heart disease with concomitant AF need anticoagulation only if their CHADSVASC score is above 2. The CHADSVASC is essentially a scoring system that determines which patients with non-structural heart disease and AF should be anticoagulated. Of course, the risk of thrombosis must be balanced against the risk of bleeding once anticoagulation is initiated, and the risk of bleeding is determined by the HAS-bled scoring system, which we will cover tomorrow. Okay, so essentially, let's dig into this. You get 1 point for each of these entities with the exception of age above 75 and stroke, in which case you score 2 points. So if you've got congestive heart failure or a left ventricular ejection fraction of below 40%, you score 1. Hypertension, you score 1. Age above 75, you score a whopping 2. If you've got diabetes mellitus, you score 1. Stroke or transient ischemic attack, you score 2. Vascular disease, any form of vascular disease, be it coronary or aortic or peripheral, you score 1. Age between 65 and 74, you score 1, and female sex, you score 1. So we said if the score is above 2, you've got to anticoagulate. So which agents are available for anticoagulations? You can use the tried and tested warfarin at a dose of about 500 grams daily to target an INR between 2 and 3, or you can use the newer, novel oral anticoagulants likes of dabigatran and rivaroxaban or apixaban. So warfarin for AF with valvular disease is a must. So we can't use our novel agents in the setting of valvular heart disease. The novel anticoagulants should not be used as well in patients who have severe renal impairment, prosthetic heart valves, mitral stenosis, or valvular lesions associated with moderate to severe heart failure. Patients at higher risk of bleeding may require low doses. Right? Bridging anticoagulation for initiation or interruption of warfarin therapy is not routinely required but should be considered in those at high risk for acute thrombosis, the likes of mechanical heart valves. All right. Well, we know that factors that increase the risk of bleeding with warfarin use includes advancing age, female sex, diabetes, prior hemorrhage, uncontrolled hypertension, alcoholism or liver disease, cancer, bleeding disorder, CKD, aspirin, clopidogrel, or non-steroidals, including your COX-2 inhibitors. But note that the risk of falls by themselves is not a contraindication to warfarin use. All right, guys, so this is an easy way to remember which patients who have non-structural heart disease in AF need anticoagulation. CHADSVASC, there you have it. God bless you and have a fantastic day.